Hello, my name is Tracy Goodman. I'm a Senior Patient Services Team Leader with Arrhythmia Alliance. Today, I'm joined by Professor Orhan Uzun, who is joining us from the University Hospital of Wales, Cardiff, and the Vale University Health Board in Wales in the United Kingdom. Hello, Professor Uzun.
Hello, how are you?
I'm very good, thank you.
Thank you very much for giving me opportunity to present our patients and parents' accounts on the topic of living with SVT from the lenses of others. I hope you will enjoy this. This presentation is based on 2023 Arrhythmia Alliance SVT Pioneers Center of Excellence winners. Patients and parents contributed to the whole slides, and my contribution is to just report it to you. On behalf of Welsh Heart Families and Welsh Pediatric Expertise Cardiology Interest Group and our patients and parents. Now I'll start my talk with my young and old friend Emily. She is under me for a long time. She wrote to me about her journey, and her narration was, living with SVT is scary. Even the smallest strange feeling in my chest makes me anxious. That something is wrong. When I go into SVT, it makes me feel dizzy, sick, and terrified. I am always scared of going into SVT, that it puts me off doing things that I find fun or want to do, like going on roller coaster. Isn't that just very, very upsetting that her SVT is interfering with her quality of life and enjoyment? And she continues, I am on medication to help prevent SVT, yet I am still terrified of it. And the side effects of my medications that make me feel ill a lot. I get worried when I forget to take my medicine on time. I worry that if I miss out on a dose, I'll go into SVT. It's a constant anxiety, constant stress and chasing of her medications in her mind all the time. I'm especially worried at night because, especially when I was younger, my SVT was only ever triggered when I was in bed at night. So if I don't feel well in the night, I often stay awake until I feel better, just in case I go into SVT. She even avoids going to sleep. How much her life is affected by it. I spent a lot of time in the hospital because of SVT when I was younger, and I've been on so many different medications to prevent that from happening. Yet it still happens, and I am still terrified of it. That's what Emily says. And who can actually stay, in my view, and in your view, I'm pretty confident, not affected, not touched by these narrative. And Emily's mum explained her journey as follows. My daughter was diagnosed with Wolff-Parkinson-White syndrome, which includes a short circuit between the top and bottom chambers and creates rapid conduction of heartbeat from the atria, top chamber, to the bottom chamber, ventricles. 12 years ago, she had the diagnosis. In the beginning, following diagnosis, I thought they were wrong because she led a normal life. There were no symptoms whatsoever. How wrong was I? A few months later, she had her first episode of SVT and spent Christmas in hospital. It was then she started on medication. She couldn't even celebrate Christmas. By the age of 8, she was on 3 different drugs, 3 times a day, and still having outbreaks and numerous admissions to hospital. Then it was enough. Enough is enough, and we referred her to our colleagues at our surgical center to have a special procedure called electrophysiology study and radiofrequency ablation. To date, she has had 3 ablations, each not lasting as long as the first one, before going into SVT again. And each time, procedure was successful, but recurred, or she had another accessible pathway becoming active. emerging out of the blue, and she was back on medication again. And we had a long discussion, and she has been discussed with the doctor, and she has just been referred for her 4th ablation. She wants to get rid of this nuisance. As a parent, it impacts on daily family life, such as we can't be too far away from her in case it happens, finding childcare for the other children when she is rushed into hospital, remembering to take all her medications with us if we went out. No vasovagal maneuvers worked, and we always knew she would have to go into hospital. Even the paramedics knew her by name. I never forget, though, despite the impact it has on us as a family and how it dictates, we always remember it is Emily that endures this, and we are helpless, and that is hard to accept. Then she goes into thanking us and about the care she received, and which is very, very humbling, and makes us think, not twice, not 3 times, 4 times, we must help this girl. I will go on to a second case, Martha. And I met Martha when she was a shadow in her mother's tummy. Martha was young when she had the procedure, therefore she has no recollection, as opposed to Emily. She's a teenager, so she remembers everything. What Martha says, and this is her heart when she was before she was born, it's just chugging along, heart rate over 200. So it started before birth. I don't remember my time in hospital, but I have seen photos, and I have one of me and my brother in the neonatal ward in my bedroom. I've heard lots of stories from my mummy and daddy about the amazing doctors and nurses that looked after me. And she just quotes on what we did and how grateful she is. And she puts some emojis. And after her procedure, she is totally arrhythmia free, and hence no longer her heart is dancing, but Martha's little legs are dancing from pleasure. And Martha's mum provided her narrative. Martha was diagnosed with SVT when I was 30 weeks pregnant. After 3 weeks of treatment on me, failed to bring her heart rate down. She was delivered by emergency cesarean section just under 6 weeks early because of worsening hydrops. It means there are a lot of fluid around her heart, around her lungs, in her tummy. For the next month after birth, we stayed in the hospital as the drug regimen she needed to take to keep her heart beating as it should was determined, and the medication worked partially. 4 different types of medication was used after she was discharged from hospital, as she was having recurrences after being arrhythmia free for a few weeks after going home. 5 times a day she was taking medication. And over the next 2 years, we were in and out of hospital with SVT episodes until there came to a point when the medication stopped working. And whether it is strange, lucky enough, I don't know, she always came to hospital, mostly, I must say, I shouldn't say always, when I was on call. And I was feeling so guilty that we couldn't help her. One day, again, we said together, Martha's mum, Michelle, and myself, enough is enough. And we decided to send her to our colleagues at our surgical center. We're grateful to our center in Bristol and our colleagues in Bristol, electrophysiologists like myself, accepting her in such a young age. She's one of the youngest one we referred from Wales. She was only 2.5 years old. And mum continues, we were told that her best option was to have surgery, meaning that the procedure, not surgery, catheter procedure, a cryoablation at 2.5 years of age. Her procedure was scheduled for August 2017. I didn't change any word, so these are not my narration, her writing. I did not edit it. Therefore, surgery, her understanding. And after a 4-hour operation, her condition had been completely cured, and I was there specifically, I went there to be in the procedure and help my colleague, Mark Walsh, and we did the procedure and interpretation together. And credit to Mark, he's been masterful and got rid of the substrate for arrhythmia. No more medication, no more pale blue skin, no more taking a stethoscope everywhere. We went, and no more dancing hard. And dancing hard, just pay attention to the word, because we set up a charity for UHW, Cardiff and Vale University Health Board, to raise 1 million with Martha's mom, Michelle, and myself for the Children's Heart Unit as well as Neonatal Unit. We are moving on our target. Dr. Uzun and his team were phenomenal, and they are going on to thanking us. As a family, right from the moment I arrived, still pregnant at the hospital, and they are expressing how grateful they are. And the charity is called Martha's Dancing Heart Charity. Now, we were having problem with our patients collecting data, documenting SVT. We struggled to capture for many years breakthrough episodes of SVT tachycardia, despite numerous Holter recordings on Emily. That's what Emily's mum writes. And also Martha's mum confirms that. During one of Emily's many clinic appointments with her doctor, she was keen to, and the doctor was keen to introduce a patient to the ECG plate and watches. This became a game changer for us all. It enabled us to capture any abnormalities, regardless of how fleeting the episodes were, and was able to email the recording directly, straight away to Emily's cardiac team. Because without documentation, we couldn't change medication. We couldn't start more effective medication, which are strong, but also come with higher side effects. And also, before doing any procedure, we had to confirm that it's a genuine arrhythmia. Emily's mum continues in her narrative. We felt that Emily benefited greatly from the ECG plate and remote ECG monitoring, which captures cardiac events that enabled her consultant to adjust her medication management appropriately if required. Then what these individuals did, who are a sufferer of arrhythmia, Martha's Dancing Heart Charity, and Leon Montanari's Heart Fund, run by her mum, Julie Montanari. Both have been working with myself to develop remote arrhythmia rhythm service, arrhythmia monitoring service, because particularly COVID-19 crisis, we had no possibility of arranging Holters for our patients. So they were suffering from arrhythmia, but there was no way of documenting it, because these devices could not be given to any patients, including adults and children, during the pandemics. So we had to do something. This could have led to serious consequences in the diagnosis and management of rhythm problems in children. Therefore, these two charities, as well as other patients, like Louis Stokes Foundation, like Emily's mom, they stepped in to help purchase and donate over 22 wireless and wearable ECG watches and ECG plates, and to develop novel telearrhythmia service in South Wales. And this was the first in its kind in Wales, if not in the UK or away. And we partnered with our patients and set up a charity and support group called Welsh Heart Families. So Michelle Graham, on behalf of Martha's Dancing Heart Charity, and Mrs. Julie Montanari, on behalf of Leon Montanari, they were pioneers and leads, and they've been playing pivotal role in acting rapidly to close the gap in children's arrhythmia service provision by demonstrating true citizen and NHS partnership. As a result, the Children's Heart Unit for Wales has been provided with these equipment for the use of children with heart problems throughout COVID-19 pandemics without any interruption of the service. And our thanks also goes to our management, directorate, particularly our clinical director, medical director, and also mostly we had unreserved support from our chief executive, Lan Richards, who was our CEO at the time. He was very, very supportive and encouraging and always helpful to us. Without his support, I don't think we would have achieved to establish this new service. And service was so successful that we went on to winning Arrhythmia Alliance SVT Pioneers of 2023 awards. And this is our team members, some of the team members. We would like to thank our patients, particularly Martha Graham and Emily Edinburgh, for providing their narrative, their story, as well as their mums, Michelle Graham, and also Emily Andrews, and Emily's mum, Mrs. Andrews. We also would like to thank our Welsh Pediatric Cardiovascular Network members, Sean Jenkins, Pram Pichiakani, Marcia Shalla, Ponemala Govindraj, Sohail Beheri, David Rollinson, Anthony Goodwin, Max Nathan, Drina Fortner, Amos von Claire Logan, who provided clinical governance and seamless access to email and instant response to parents, my secretary, Caroline Keogh, and also Julie Montanari, who supplied endlessly watches and ECG plates to us through her charity, Leon Montanari Fund, along with Michelle Graham through her charity, Martha's Dancing Heart Charity. Thank you very much for listening. And I was humbled and overwhelmed with the stories of my patients and parents, seeing the life they are having through their lenses. It was very, very moving. Thank you very much. I hope you enjoyed it. And I hope that our story will also provide some impetus and will allow this service to be spread around the country and beyond. Thank you.
Thank you, Professor Uzun, for that very personal account of SVT and how you've had such an impact on your young patients in particular. So we'd like to thank you very much for that. I do have a couple of questions that we've received regarding SVT, if that's okay. So one of the first questions we've got is, what causes SVT initially and what are the main symptoms to look for?
The mechanism of SVT may be different in each patient. Most common one in children, like Emily suffered, and Martha suffered due to extra piece of muscle connecting top and bottom chambers. Those muscles, they are present up until 8 weeks, 9 weeks of gestation. Afterwards, they disappear. Top chambers and bottom chambers become insulated from each other, and they can only touch each other via a special conduction tissue. And in some patients, not only conduction tissue, AV node and bundle branches, but also those extra piece of muscle may be providing escape route. And that's the commonest cause. We call that accessory pathway related tachycardia. Second arrhythmia may be related to automatic focus. So randomly beating, randomly firing, automatic focus escapes the control of our own pacemaker, which is called sinus node. Sinus node, usually the boss, sits on top of right filling chamber and suppresses any unwanted electricity escaping from the muscles of the top chamber. But sometimes, at times of illness, at times of various reasons like electrolyte abnormality, or sometimes electrical cells might be embedded within the atrial muscle during development, they automatically fire. So we call that automatic focus. And the third mechanism may be triggered mechanism. That triggered mechanism due to excessive calcium loading or genetic conditions. So there are three major reasons. And the fourth one is usually seen in teenagers and adults. Our own conduction tissue between the top and bottom chambers. It's like a little node, atrioventricular node. And that node, like peanut size, may have two horns, one horn at the back, one horn the front. Sometimes they may not work in coordination. They should work like a newly married couple. But one of them may be overactive, the other one less active, and they compete. They might allow impulse to turn around like extra piece of muscle. They create short circuit like extra piece of muscle, but this is within our own conduction tissue. So those are the four forms, major forms. And the symptoms: before birth, babies present with fluid around their hearts, fluid around the lungs, fluid in the tummy, and heart failure. May sometime, unfortunately, babies may not survive. Luckily, our success rate with arrhythmia control before birth has been exemplary. In fact, our protocol has been used and copied all around the world. And we've been pivotal in advising other centers and being at the forefront of treatment of SVT. And after birth, these babies may continue to have arrhythmia, or arrhythmia may emerge after birth, any age, immediately after birth, within a week, 2 weeks after, first year, in childhood, or sometime in teenage years, and rarely in adulthood. So adulthood is due to wear and tear and scar tissue inside the muscles of the filling chamber or pumping chamber. But if it is SVT, it must be in the pumping, not pumping chamber, but in the top chamber. SVT stands for supraventricular tachycardia. It means the focus coming from above the pumping chamber in the filling chamber. So if you're a newborn, you present with feeding difficulty, not growing well, being sick, vomiting, or very sleepy, or crying inconsolably. So it is completely non-specific sign. But sometimes moms might notice it when they put the chest of the baby on their breast, and the heart must be chugging along, and might be chugging along, and mom might notice heart is never slow, even when baby is sleeping. So that might be also noticeable. Sometimes baby's neck might be pounding, or chest might be pounding uncountably. Sometimes mothers might listen to the heart. It may be uncountable, very, very fast. But majority of babies diagnosed with non-specific symptoms: breathing difficulty, breathlessness, not being able to finish the bottle, not putting weight on, being sick, or crying a lot. When they are older, symptoms are the same if the children cannot express themselves, or may present with collapse. So that also not very common, but not infrequent. So we have at least half a dozen patients every year presenting with collapse, and babies are very unwell and they don't know what it caused by, and this is a diagnosis by exclusion, sometimes pure luck. Pediatricians in Welsh District General Hospitals, we're very proud of them. They are very alert, and our team members, when they do an ECG or when they put the monitor on the chest, monitor leads, and it shows heart rates over 200, and diagnoses are confirmed. All the children can express that, but they don't say my heart racing. They say, oh, I feel funny. I feel butterflies in my tummy, not the chest, in my tummy. Or they might say, I feel dizzy, mommy. I feel sick, daddy. So they may fall behind their friends, or they may genuinely fall. They may faint when they are moving around. All the children, of course, they would perceive. They would say, my heart racing at rest. and my heart thumping. That's another word they use. Or I have skip beat. And some children may not notice it if the heart rate is not as high as 200, 220. It may remain unnoticed if the heart rate between 150 and 180. We call that slow tachycardia. And those patients come in with heart failure a year after, because tachycardia continues in the background. They may think, oh, child is very anxious, very sweaty. So that's not very common, but we see about 1 or 2 patients every couple of years presenting with heart failure as a result of unnoticed fast heart rhythm. And of course, in older children, you can easily document by going to the A&E, having an ECG, or with the new fancy watches, they make recording of their heart rate and even the ECG, and they may present it to us. Those are the symptoms. And some symptoms occur as sudden death. That occurs mainly beyond 8 years of age, and as a result of Wolff-Parkinson-White syndrome that Emily suffered from. And we have about 1 patient every year collapsing during football, collapsing during rugby, collapsing during PE. And recent child came from a district general hospital, and he was playing football at school. Luckily, school had DC defibrillator, and he was defibrillated. He was indeed having exactly the same condition as Emily suffers, Wolff-Parkinson-White syndrome, and that causes rapid conduction from top chamber to the bottom chamber, where the heart cannot fill, cannot pump, as a result of low pressure, low oxygen in the heart as well as in the brain, and patient develops very low blood pressure, and they collapse. They cannot maintain circulation. But child was luckily converted to sinus rhythm, and we treated child effectively and put the effective medications. Collapse and sometimes death might occur, and that's usually something in the past, hopefully, and it might even happen in adults. Risk is about 10% in children, goes up to 30% in adults.
Okay. So that just goes to prove, doesn't it, that remote monitoring and close identification of the symptoms is very important in diagnosis.
Absolutely. But not just identification of symptoms, also educating parents and also educating school, educating groups, clubs, and also providing defibrillator for those common places. We would like it to be widespread. Absolutely. And also, we would like the A&Es, hospitals, and emergency services to be aware and document those arrhythmias straight away. And we would also encourage patients, perhaps, to acquire one of these devices to be present at home. We do provide, but we take them back 6 months after. We do provide, hopefully we'll provide them free of charge in the future with the help of our selfless parents like Julie, like Michelle, like Lottie, Louis Stokes' mom, Hannah, Hannah, again, our patients' parents, and also other members of our team. They also raise money. I must say also our health board and Nozart Charity.
Absolutely. So you mentioned you talk and you obviously deal with mostly pediatric patients. How soon would you advise a catheter ablation procedure in a young person?
I would advise any time to be done. However, there are risks. We only do procedure in neonates when we are in dire straits. In a small heart, you may damage patient's own conduction tissue. You may cause a scar which grows with the heart's growth as the child gets bigger and might cause more problems in the future. Therefore, we do only in neonates and infants when medication didn't work and child is in heart failure and we cannot control arrhythmia with medication. And so far in Britain, to my knowledge, before COVID, we had done in no more than a dozen or 15 neonates. we used to wait until they reach 12 years of age, or reach something like 40 kilogram. But after having more insight into Wolff-Parkinson-White and seeing this even in unborn babies, we thought unborn babies wouldn't have atrial fibrillation because Wolff-Parkinson-White doesn't kill. What kills you? 10% of patients with Wolff-Parkinson-White in children, 10% in adults, develop atrial fibrillation. It means uncoordinated, very rapid heartbeat in the top chamber. And if you don't have accessory pathway short circuit, the AV node, natural pacemaker or gateway, does not allow more than 260 beats to go down, 280 maximum. But accessory pathway allows even 300, 400, 500. So Wolff-Parkinson-White in small children wouldn't cause atrial fibrillation and ventricular fibrillation and sudden death. But we know it happens even in small children and in young people. And after seeing that in small children, and a 6-year-old child of patient of ours collapsed during holiday, we airlifted him and did the procedure when he was only 30 kilogram. Therefore, we actually moved our goalpost to young age, 35 kilogram ideally, and to beyond 6 years of age. But if we're desperate, like Martha, when they are 15 and over, and around 3 years of age, or more than 3 years of age, when we're desperate, we're bring it further. So 3 years of age is doable with less damage. Less than 1 year of age, when we're desperate, 6 months and 35 kilogram over is now standard in patients. The best result is achieved at 12 months of age, at 12 years of age, or when they're about 40, 50 kilogram, because heart reached adult size we consider between 12 and 14 years of age, and scar tissue will not grow. And you don't damage to the conduction tissue, normal tissue is less likely.
Professor Uzun, one of the questions that we receive quite often into patient services is what triggers SVT? Can lifestyle changes help with that as well?
Thank you. That's a very good question indeed. Yes, some activities or some determined illness or prior illness or current illness, particularly the febrile ones, or diet habits might trigger it, such as excess caffeine consumption and medication containing stimulant substances like adrenaline containing even nasal drops, some adrenaline containing medication for dental treatment, some adrenaline containing flu medications, sometimes excessive consumption of chocolate, coffee, tea. So those are the substances that we should pay attention to. Nicotine must be avoided, of course. We don't want any of our patients or youngsters or even adults to have nicotine-containing beverages or nicotine-containing substances to smoke. And some energy drinks contain excessive amount of caffeine. We would like this to be avoided. And activities, we don't want to stop our patients from undertaking activities. They must enjoy what young children must do. And as long as they are on medication covered, they should be safe. But they should be aware of it, and they should learn what to do with tachycardia when it recurs. They must stop immediately, lie down, and they should hold their nose, pinch their nose, and blow their cheeks out. It's called Valsalva maneuver. And they should put their legs up and sit up from sitting position, or from lying position, they should sit up. They should lie down, blow into a syringe, or blow their cheeks out by pinching their nose. They should keep going for 10, 20 seconds until they tolerate it, and with their legs up, and they should put their legs down and sit up. And also crunching ice or drinking very cold ice water would help. Rubbing their neck around their chin would help. Also managing the illness and taking antipyretics if they have temperature, and managing the illness itself would calm the heart rate down. Diet is important, as I said. Eating magnesium-containing food. Magnesium is very rich in nuts, if you're not allergic, and egg, fish, milk, and the diet is somehow helpful and might actually reduce the frequency and duration of tachycardia. Potassium-rich diet is good in grapes, plums, fruit and vegetables, in tomato, in oranges and potatoes, and so on. And we should, as I said, avoid excessive calcium, perhaps, if it is triggered mechanism, or we don't want to deprive our patients calcium, which is important for the growth of their bones. But if they are drinking liters of milk, it should be brought down to sensible amount, but that's only for triggered, which is calcium-induced tachycardia, automatic tachycardia. And that's all I would like to say. I hope it will be helpful for patients when they are somewhere that they cannot get hold of emergency services, but they can control their arrhythmia by stopping immediately. They must not continue, even if they are going to score for Wales in rugby, a try, even a goal for England, they must stop and lie down. That's very important. Otherwise, they will collapse.
Yes, absolutely. Thank you so much. Your account of living with SVT, particularly in paediatric environment, is very important, and I'm sure many patients will find it very beneficial to view your video. So I'd just like to say on behalf of Arrhythmia Alliance, thank you very much for taking the time to talk to us today. Thank you, Professor Uzun.
Thank you very much for giving this opportunity to us on behalf of our patients, parents, and fundraisers, as well as our network members in Wales and our hospital management. Thank you.
Thank you.